So I thought these were worth looking at. These are data from a survey from the Alzheimer's Association of subjective memory complaints and cognitive decline in older adults. And I thought it was curious that the rates are relatively even across lifespan. In fact, seem to go down a little bit in the 80+ group. And that percentage of 11.6 people with subjective complaints about memory and cognition, 80+, that's about half or a third of the rates of dementia in that group. So it's interesting that middle-aged people are complaining as much as people over 80. And so I think that says something about when cognitive impairment really does accelerate, people are maybe less inclined to mention it or complain about it. Perhaps they're comparing themselves to their age peers. People in the middle age groups complain about it because it's a nuisance, even though it doesn't necessarily represent a progressive decline. Next one, please, Jonathan. So to understand cognitive impairment and cognitive aging, you have to have a sense of what's normal. And these are the kinds of things that are normal, that people may not be paying attention. They may be a little distracted. Information doesn't encode quite as efficiently as people get older. But if you're paying attention and you rehearse, you can encode information reliably, and you don't have to ask questions repeatedly. Next one, please. And I'm going to close my door. I'll be right back. Okay. So these are the kinds of things that should raise questions that there's something going on beyond normal cognitive aging. Getting lost in a familiar place, problems navigating in your hometown, not being able to follow a recipe or directions, telling the story more than twice in one conversation. That's my plateau or threshold. That I'll raise an eyebrow, or asking the same question more than twice. If I do it, it's okay. I can ask a question twice. I do often. And my colleagues are tolerant of that. I don't ask the same question 3 times though. And if you have a real personality change, I'm assuming I'm normal. I'll add that to that last comment. Real personality changes may also indicate a neurodegenerative process. Can also represent a medical illness or depression. So losing interest in conversation, apathy, disinterest in leaving home, not taking good care of yourself, not showing an interest in other people. These are other warning signs. Next one, please, Jonathan. So these are sort of classic data, and they show that the speed-dependent cognitive functions like visual, spatial, reasoning ability, and also learning new material, memory, peaks in your 20s, and it's pretty much downhill from there. These functions are called fluid intelligence. I like to think of it as flowing downhill. And you can see that the slope sort of accelerates after age 70. That's the influence of an increasing effect of neurodegenerative diseases like Alzheimer's disease. Crystallized intelligence, here signified by vocabulary, tends to increase like a mountain, granite, increasing, plateauing at age 60. I guess our brains are full. But I think it also reflects the increasing incidence of degenerative changes. Next one, please. So these data are relevant to highly educated people who tend to score higher on standardized tests than others do. This study cracks me up because they looked at 1,002 MDs, physicians, and they consider us not to be normal, so they compared us to normals. They actually wrote that. And you can see that highly educated people score above the average on this cognitive test, which is a computerized battery. But after age 70, there is this very rapid decline, and it's really reflecting of the higher incidence of degenerative dementia. Next slide, please. So when we drill down a little bit on memory, there's this crystallized knowledge which is preserved, remote memory and instinct and procedural knowledge and vocabulary, all increases or is well preserved throughout life. It's the episodic memory, recent memory, recording information about events or conversations or new learning, which is most sensitive to age effect. Next one, please. So if we plot that gradual decline from degenerative diseases against normal aging, most people stay pretty stable throughout life. Some decline, as I mentioned, in speed-dependent cognitive functions and memory. But there are an increasing number of people who start to show deviation from normal, and they progress through a phase called MCI, or mild cognitive impairment. Next one. So I want you to just think about normal cognitive aging versus MCI versus dementia in the realms of recall and learning, executive function and reasoning, navigation ability, speech and personality and behavior. And the biggest difference between normal aging and MCI is mostly in recall and learning, new memory, whereas people with MCI should have relatively intact functions in these other ways. It's normal for healthy older adults to have some problems with episodic memory and WFD, which is word finding problems, word finding difficulties. So word finding difficulties are common and frustrating. WFD sort of leads to WTF expressions, but it's very frustrating. But it doesn't necessarily mean that you're progressing down this slippery slope. Next one, please. So mild cognitive impairment, which is also called mild neurocognitive disorder in DSM-5, is defined by a measurable decline in memory and or executive frontal executive cognitive functions to the lowest 10 percentile of your age group, and that's 1.5 standard deviation units below the mean. But generally, people can still function independently with this condition. But it's a transition phase to Alzheimer's disease when it's primarily memory impairment. Now, the prevalence is about 18 to 20% of the population, but it's very dependent on age, sex, and other risk factors for dementia. And I mentioned these people can generally live independently, but as their condition progresses, they're more subject to financial scamming, medication errors, traffic accidents, and psychiatric symptoms, sometimes called mild behavioral impairment. And that's a term I hate, and I hope you forget it. And I'm going to move on, because I'm going to forget about it. All right, now this slide is a little complicated. I just want to make one point. It shows neuropsychological features of different forms of MCI. On the left is amnestic MCI, which is generally a prodrome to Alzheimer's disease. And on the right, you see those bars going down. Those are memory tests below 1.5 or almost 2 standard deviations below the mean. This is the amnestic MCI, the prodrome to Alzheimer's disease. In the middle is impaired language MCI. They do poorly on verbal fluency tests, animals, and Boston naming tests. This is often a prodrome to frontotemporal dementia, along with behavioral and personality symptoms. And on the right are the dysexecutive or mixed MCI. These are people with more executive function problems, here illustrated by poor performance on the trail making test, where you connect the dots. That's a processing speed issue and a visual scanning issue and a cognitive flexibility task, very sensitive to vascular disease. Most of these people have vascular disease. Some of them may have depression, some of them may have Lewy body disease. It's sort of more of a catch-all than the other two categories. Next one, please. Psychiatric conditions like schizophrenia and anxiety disorders also can contribute to MCI. Anxiety disorders and depression especially. They may be early symptoms of the dementia, but if a person has recurrent anxiety, lifelong anxiety disorders, or late life onset mood disorder, they could certainly have cognitive problems that may improve if you can adequately treat their anxiety or mood symptoms. Next one. So I want to encourage you to use a standard scale like the AD8 as a functional assessment based on an interview with a family member. This is, there are 8 questions on here, and in the family would say, yes, there's been a change in one of these activities, or not a change. If they endorse 2 or more of these symptoms, then the person is likely showing cognitive decline. Doesn't mean they have Alzheimer's disease. It just means that they're showing some symptoms and need to be evaluated. Next one. Now, the CDR is the Clinical Dementia Rating Scale. This is the gold standard assessment tool based on a structured interview with the person, with the problem, and the family. And it goes from no cognitive impairment, questionable cognitive impairment, which is MCI, and then mild or moderate or severe dementia. And we use this in research to define stage, but it's a very useful clinical instrument too, and you can just use it subjectively to help you define where a person is in these 6 domains of function: memory, orientation, judgment and problem solving, community affairs, home and hobbies, and personal care. People with Alzheimer's disease will tend to move to the right initially. People with vascular disease or something else may show problems with the lower functions first before they really show severe problems with memory or orientation. Next one, please. And there are many functional assessment scales. This is the Functional Activities Questionnaire. This is a useful thing just to document what a person can and can't do. It can augment the Clinical Dementia Rating Scale or the AD8. Next one, please, Jonathan. So here's a MoCA, Montreal Cognitive Assessment, from someone with MCI from Alzheimer's disease. And you can see there's a little softening on their trails B and their mini trails B, connecting the dots in the upper left-hand corner. Their cube copy is a little funky, but not too bad. They only got 1 of 5 on delayed recall. This is a very typical early Alzheimer's disease person at the MCI stage. Next one. And here's an MCI. See, I remembered to cover up the name. Here's a person transitioning from MCI to mild dementia. They're scoring an 18 overall. Their memory is 0 out of 5. They're starting to get some orientation questions wrong, and the top of the visual, spatial, and executive functions are now obviously impaired. So this person may not be able to live alone anymore, or at least needs frequent check-ins and monitoring. Next one, please. We've recently realized, I'm surprised it's taken us this long, that there's a lot of false negatives using standard cutoff scores for women because of their superior verbal skills and superior verbal memory. I'm always amazed at how well women can remember conversations. If the MoCA, if the MoCA included how much horsepower did a 1964 Ford Mustang have, then then we would you'd have to give us 20% handicap. But it turns out that we should probably use higher cutoffs for women on scales which are more verbally dependent. Next one, please. This illustrates the transition of mild cognitive impairment from Alzheimer's disease as it progresses from the medial temporal lobe on top to progression into the frontal cortex and parietal lobe, which signifies the transition to mild dementia. And then over on the right, there's pathology now involving more brain area, causing ongoing functional decline. Next one, please. Next one. About 2/3 of cases of mild cognitive impairment are due to Alzheimer's disease, both in the memory clinic and in the community. Another 1/5 or about is due to vascular dementia, frontotemporal dementia, also a little less than 10%. And then Lewy body disease and a variety of other conditions rounded out. But in sample after sample, about 2/3 of cases are primarily due to Alzheimer's disease. Next one, please. And we define Alzheimer's disease in the MCI stage or the dementia stage as having an insidious onset, worsening over time, typically an amnestic presentation with memory problems, without any other condition to account for the problem. If there is evidence of something else like depression or cerebrovascular disease, then we might say this is possible or mixed MCI or mixed dementia with Alzheimer's disease as the primary condition. Next one, please. We have some imaging capacity. This is an amyloid scan from one of our research studies to document Alzheimer's disease in the brain. Next one, please. This is another type of PET scan that we can use to distinguish frontotemporal dementia from Alzheimer's disease. Next one. I won't go into details, but we have those capabilities. And scroll through the next 3 slides, please, Jonathan. I just wanted to give you these slides as examples of other pathologies that are more not uncommon in people over 85 in whom Alzheimer's disease is a much less likely condition. I do want to spend a moment on frontotemporal dementia. This is a degenerative dementia of midlife. Several diseases under this heading. Typically, they're in their 50s and 60s. There's a behavioral variant in which there's primarily personality changes before cognitive ones, and there's an aphasia variant where there's speech and language problems before other cognitive or behavioral symptoms come up. So I want you to think about this in the middle-aged person who's showing some evidence either of language problem, behavioral issues, and is starting to show some cognitive problems. Next one. Vascular dementia was first described in the 1890s by Binswanger and Alzheimer, 2 neuropsychiatrists in Germany. It was long thought to be the primary old age dementia until we realized Alzheimer's disease was doing that. The onset of the symptoms can be related to a stroke or just related to small vessel disease from hypertension or diabetes, and it can come on insidiously, sort of like Alzheimer's disease, but it primarily causes frontal executive problems more than memory problems, although it affects memory too. If a person really does have amnestic symptoms, they can't retain information, then they may also have Alzheimer's disease. Next one. And then finally, Lewy body dementia is quite common in older adults. These are people who have fluctuating attention and concentration. They may have visual hallucinations and Parkinsonism. They frequently have a condition called REM behavior disorder where they act out dreams. They may punch and kick and call out, jump out of bed. It can be quite dramatic. Quite common in Parkinson's dementia and and Lewy body disease. Next one, please. Just another couple of minutes. In this study, looking at people with mild cognitive impairment, 42% of them had progressed to dementia at 5 years and 53% at 9 years. So yes, they progress over time, but not all of them do. And you can see that after 9 years, 41% of them had stable MCI. So depending on other risk factors, people can stay fairly well and fairly independent for quite a long time, but many of them do progress over time. You can see in that middle, the red arrow cohort, quite a few of them are progressing to dementia from Alzheimer's disease. Next one. This is a complicated slide. I just want to turn your attention to the top left-hand corner and the red line showing a rapid decline at from the beginning of the study to about year 9. About 90% of these people with MCI had progressed to dementia if they had very low levels of education and low socioeconomic status. People in the green cohort, well-educated people, had a much slower progression to dementia. We can also look at hippocampal volume and cerebrospinal fluid markers to develop a prognosis or a likelihood that people will progress to dementia. And we're doing this in research studies. Next one, please. All right, so I just want to finish up by talking about treatment planning. So if you identify a person with cognitive impairment, you have to think about sleep disorders, thyroid problems, diabetes, also managing hypertension, which is a risk factor for progression, depression, anxiety, and medications contributing. You have to monitor them at about six-month intervals to chart their progression to see if they're still safe to drive, still safe to manage finances, still safe to take medications. It's worthwhile exploring clinical trials to see if there are experimental treatments they may be eligible for. Discussions about lifestyle factors like diet and exercise that can affect prognosis. Advanced directives and legal and financial matters have to be discussed. Next one, please. So the Alzheimer's Association recommends these 10 ways to slow progression to MCI and from MCI to dementia. So this is available on the Alzheimer's Association website. It's a good thing to print off and hand out to your patients. Next one. And I want to just turn your attention to the lower table. These are potential protective factors and the evidence, strong, moderate, or weak. We know that years of formal education, I've shown you that a couple of times, there's strong evidence that reduces your risk of MCI and of transition from MCI to dementia. Physical activity, also very strong evidence for prevention of cognitive impairment. The Mediterranean diet, fairly good evidence. They call it moderate. I would agree, but good evidence. Cognitive training or exercising your brain, some evidence for that. Next, please. The Healthy Brain Initiative is from the Federal Center for Disease Control, the main Center for Disease Control, and I think I'm pretty sure New Hampshire and Vermont are also following the federal lead to institute these known behaviors that can help preserve healthy brain aging. We have a study called the Maine Initiative for Neurologic Aging and Health, or MENA, that people can all over New England at any age can register for to stay updated on potential research opportunities and brain healthy information as new research comes out. So you can download that at the MENA website. Next one, please.